Okay, so again, welcome to part 3, where we are going to discuss chronic care management. Today, we're going to go through the required elements for chronic care management, successful coding and billing, and finally, we're going to look at how you actually implement chronic care management at your practice. As a reminder, here are the timeline overview of CMS preventative visits. In 2013, the ACA began paying for transitional care management services under CPT codes 99495 and 99496 with the goal of reducing readmissions. We discussed this last week on part 2 of our webinar series. And then in 2014, CMS started paying for chronic care management services. 2/3 of Medicare beneficiaries have multiple chronic conditions, and in an effort to keep patients out of the hospital, CMS began paying for management services that include non-face-to-face visits. So we went from 2011, where we really focus on directing care to the primary care provider, to 2013, where we're focusing on reducing readmissions, and then coming sort of full circle to 2014, keeping patients out of the hospital altogether. The annual wellness visit, as we reviewed in part 1 of this series, is a comprehensive care planning visit that includes completion of various screenings and health risk assessment. And as a reminder, this is not at all a head-to-toe physical. It's more of a conversation with your primary care physician. And in this visit, the patient and healthcare provider create a prevention plan based on the patient's health risks and needs. The annual wellness visit has actually 3 separate codes. There's a welcome to Medicare visit, the initial annual wellness visit, and then following that, the subsequent annual wellness visit. And if you want to check out the specifics on AWVs, you can check out part 1 of this series posted on our website. Transitional care management visits, known as TCM, is a service provided following discharge from any inpatient facility. And this service actually includes both non-face-to-face and face-to-face visits. And this visit is designed for patients who have medical or psychosocial problems that require moderate or high complexity medical decision making. And when the provider bills for this code, they're really taking responsibility and ownership for the fact that they are going to manage the patient's care following discharge from a facility setting. And finally, today we're going to talk about chronic care management, or CCM. And these are exclusively non-face-to-face services provided to patients who have multiple significant chronic conditions. These services include communication with the patient and other treating health professionals for care coordination, also for medication management, and the provider has to be accessible to the patient 24 hours per day. And it also involves creation of a care plan very similar to that annual wellness visit. So let's dig into CCM. What are the key components? Again, these are non-face-to-face services provided to Medicare patients who have 2 or more significant chronic conditions. The key components in order to build CCM include communication with the patient, both electronically and by phone. So that means having an EMR with a patient portal that can be accessed easily. That also means having a telephone line that can reach directly to the provider. Accessibility to patients and other providers 24 hours per day. So if I'm the primary care provider managing a chronically ill patient's care, I need to be accessible to both my patients and my patients' other providers, their specialists, their cardiologists, their psychologists, whoever else they may see 24 hours a day. And this doesn't necessarily mean that you are on call 24 hours a day as the provider, but it does mean that patients can access a provider who has access to their chronic care management care plan. We can talk through the specifics of that in a little bit. The third component is communication with other healthcare professionals for care coordination, both electronically and by phone. So being willing to work with that patient's care team, their cardiologist, their endocrinologist, etc. And then finally, medication management. This is a huge part of CCM. Most of our chronically ill patients are on many medications, and medication management is key to keeping them healthy and out of the hospital. Who can provide chronic care management services? So any licensed clinical staff member, in addition to medical assistants and nurses who are generally supervised by the clinician, may actually perform CCM. So we're going to make a distinction here between who can perform it and who can bill it. So a physician, advanced practice registered nurse, clinical nurse specialist, or physician assistant can actually bill for CCM. So what that means is that if the CMA is going to perform the chronic care management services, the physician must supervise those services and then can bill for chronic care management. The activities performed during a normal CCM visit are going to include comprehensive care plan development and maintenance, contact with patient and or caregivers, contact with other providers of care, and perhaps contact with the pharmacist. Let's break down the billing requirements. So we have multiple codes here for chronic care management. The main code is the second one you're going to see on the left there, 99490. This is CCM services, at least 20 minutes per month. These reimbursements, as a reminder, are adjusted based on geography. So this is just a national average for you, but you would want to check with your local MAC to get the actual reimbursement for your area. So we have a care planning for CCM code. So in that initial CCM visit, you can build this G0506 care planning code, which is going to involve the creation of your initial care plan. Then the 99490 are CCM services, at least 20 minutes per month. This is your ongoing care management service. If you have more complicated service, 99487, this is 60 minutes of staff time per month. So we're going up from 20 minutes to 60 minutes, and you can see the change in reimbursement there. And then 99489 is each additional 30 minutes of clinical staff time. So let's say you spent an hour and 45 minutes. You could bill both the 99487 and the 99489 codes. And then collection and interpretation of physiologic data digitally stored or transmitted by the patient or a caregiver requiring a minimum of 30 minutes. This is an interesting code here. So if you're getting information for your care management patient via the EMR, either from the patient or from a caregiver, from another physician, you can bill this 99091 code as well, as long as you spend at least 30 minutes working on that information. So a couple requirements here in order to bill these codes. The first is that you have to have patient written or oral consent to bill. So this is an update here. It used to be that we had to have a written patient consent on file. Now we can have oral consent. Now that oral consent must be documented in the patient chart. And it has to be explained to the patient that they will generally have a copay. So Medicare is not reimbursing for 100% of the service like they do for the annual wellness visit and the TCM visit. Generally, the patient has about a $7 to $8 responsibility for that 99490 20-minute per month code. Additionally, to bill, you have to be the only clinician to bill a CCM service during that calendar month. What that means is that if a patient is involved in a chronic care management program with their cardiologist and their PCP, only one provider can bill for this service per month. The third requirement is that you cannot perform any of these other services during the same month that chronic care management is billed. So if you perform a TCM visit because they were discharged from an inpatient facility, we can't bill chronic care management that same month. Also, if you bill home health care supervision, hospice care supervision, and certain ESRD services, we can't bill the chronic care management service in addition to those other codes. Also important to note here that there are specific documentation requirements for chronic care management encounter notes. So the first is document patient consent. And if they're participating elsewhere, note with whom. So a best practice for this is to create a template in your EMR for CCM consent. I can't tell you how many times I've reviewed a chronic care management note and there's no consent anywhere in the patient's chart. That's a big no-no because we want to make sure our patients understand that they're likely going to be responsible for part of the reimbursement for the visit. The second required element is to document a comprehensive care plan that addresses all of the patient's medical, functional, and psychosocial needs. Also provides a system-based approach for receiving all preventative care services, reviews adherence to medication, and assesses an inventory of resources and supports. So a best practice tip here is to create a welcome letter for patients who are going to be enrolled in your CCM program and include a checklist for them so that they can get the most out of their CCM call. Once this care plan is developed, it's really important that the care plan items are addressed with the patient each visit. And in order to do this, we've noticed when working with patients, it's really important to accurately prepare them for what they can get out of the visit. So if they're just going to use this 20 minutes to chat about the craziest thing that happened to them that week, we're not going to really get the full value out of the visit. The fourth element is to document 20 minutes of non-face-to-face clinical staff time. This is key here. Because this is not a visit where the patient is actually presenting to the office, we have to make sure we can prove how the staff's time was spent so that we have documentation of services performed if we were ever audited. So a best practice tip here is to create a way to track time in your CCM visit encounter, either through templates or use some sort of tool that sits on top of your EMR to track total time working on patient activities. And as a reminder here, this 20 minutes can be spent working with a specialist that provides care to them. It can be spent communicating with a caregiver about medication changes. It can be spent actually talking to the patient. It can be spent reviewing notes from other providers that the patient may have shared with you. So we really want to make sure we get credit for all the time that we're spending on care of this patient. The last documentation requirement is that if after-hours care is provided by a clinician that's not part of the practice, that physician must have access to the care plan. So this is a big one here. We understand that providers are in call groups and that they're not going to want to be accessible to their patients 24 hours a day, 7 days a week. And so they share call with other providers. That is absolutely okay, and you can still meet the requirement for being accessible 24 hours as long as any provider who is on call for you has access to the patient's care plan. That's really important for chronic care management patients because it's a documentation requirement. But when we think about best practices, it would be great if providers who are taking on call also had access to other patients' information as well. So the best practice tip is share after-hours call lines with providers who share your same EMR. So if you're in a large medical group and you have access to all patients in your practice through your EMR, share a call with those providers or find a way to share care plans via technology or through your accountable care organization. So however you're going to divide up the call responsibilities, make sure that the provider on call has access to care plan information for these chronic care management patients. How can we implement CCM in your practice? Let's go through step by step. So step one is really identifying your patients. We have to have patients with 2 or more chronic conditions. So you want to somehow run a report out of your EMR and identify patients who meet those criteria. Step 2 is to designate clinical staff for each identified patient. We found a lot of success building care teams so that each provider and CMA or nurse can work as a unit for a patient panel. Step 3 is design a chronic care management process, a template, and a schedule. So understand how you're going to consent the patient, how you're going to document in the note, and then what your scheduling protocol is going to be. Are you going to schedule a 20-minute time slot in the provider's schedule every month to make sure that they reserve that 20 minutes to do chronic care management activities? Is it going to be on a separate chronic care management schedule so that the MA or nurse is really responsible for owning those duties? Figure that out amongst your practice. Step 4 is going to be inform the patient. Patient consent is best done in the office. A great way to do that may be to have the patient for their annual wellness visit, and if it's a patient that you've identified in step 1, you could explain the chronic care management program to them and offer enrollment as part of their health risk assessment and sort of care planning for the year. Step 5 is create and document a comprehensive care plan. And again, the stronger your EMR template is, the easier this will be. The care plan has to have all of those elements we discussed in previous slides. Step 6 is provide the patient with a copy of their care plan. And I would add here that it should be the patient and any caregiver that is providing regular care to the patient so that everyone is on board with the care plan. Step 7 is documenting the time spent. So we have to meet that 20 minutes at least per month. And if you want a code for those more complex visits, making sure that we meet the 60 and then additional 30-minute requirements. And then step 8 is documenting termination from the program. So either if the patient no longer has 2 chronic conditions, which seems pretty unlikely, but let's say they have their diabetes under control after participation in this program, that would be great. They'd no longer be eligible, so you would document termination. Or if the patient moves on to a different level of care and is no longer a good chronic care management patient. Let's talk through a case study to sort of encourage you to do chronic care management in your practices. So here we have a patient. This is Gail Summers. She's 75 years old. She has diabetes, hypertension, depression, and also a history of breast cancer. She was previously hospitalized for a foot sore due to diabetic peripheral neuropathy, and she's also had a lumpectomy because of her breast cancer. She is having some foot pain, so that's her current symptom. We have 2 scenarios here that she may encounter. Scenario A is going to be a coordinated care management effort. So she's actually flagged for chronic care management when she's seen in the ED for her foot sore, which means that someone in her office reviewed a CRISP report in Maryland, or some health information exchange report, and noticed that she was in the ED for a foot sore. Her PCP sees this, immediately assigns her a care manager, and refers her to a podiatrist. And because now she's assigned a care manager, she has regular 20-minute monthly calls with that care manager. During one of these calls, her foot pain is discovered. The care manager is able to schedule her a visit with both her PCP and her podiatrist, and the wound is examined and cleaned. You can see, excuse me, the CCM call costs $40. The office visit's about $275. So the overall burden on the healthcare system is $315. In scenario B, we have no coordination of care. She sees her PCP on an annual basis, but when she's asked for details about the ED visit, she can't really remember what the ED physician told her about her foot pain. And in this scenario, her PCP isn't reviewing any ED list or health information exchange report. So she's sent home after her annual visit, and her foot pain worsens, but she kind of forgets about it because she slumps into a depressive state, and she doesn't have that care manager regularly checking in with her. She spikes a high fever, and she's on the phone with her daughter, and her daughter encourages her to call 911. She's rushed to the hospital, seen in the emergency department, and then she's actually admitted because of an infection that had started in her foot. So the outcome here is that she's discharged 3 days later with orders to follow up in the hospital's transition to home clinic. So the burden on the healthcare system in scenario B is much larger. We see there's an ambulance ride, an inpatient stay, which all amounts to a much higher cost of care. So we'll pause now and take any questions that you all may have. I think I saw a few come in while I was chatting. Please, again, feel free to chat them in. So the first question is, can you bill for chronic care management during the same month as an annual wellness visit? The answer is yes, you can bill for CCM in the same month as an annual wellness visit. However, you cannot bill for CCM in the same month as a transitional care management visit. Second question we have here is, can you bill for CCM more than once a month if clinical staff devotes more than 20 minutes with the patient? So you can bill for CCM for that 99490 code, and then you can bill the additional time codes, but you can only bill that 99490 once per month. But if it is a complex visit and you spend 60 minutes or more, you can bill those other two additional time codes. So I'll stay on the line for another few minutes and see if any other questions come in. Okay, we have another question. Can you bill for a E&M sick visit if you're billing for chronic care management? So yes, the reminder here is the chronic care management codes are for non-face-to-face services. So if you have a chronic care management visit, let's say you have a 20-minute discussion with the patient, you're going to bill for that CCM patient, that CCM visit, and from that visit, discussion is had and it's decided that you should come in a few weeks for a visit with a provider for a sick visit for an E&M 99212 or 213. You can bill for both of those codes. These have been great questions. Thank you so much for your participation. I'll stay on the line for another minute and see if we have any other questions. Okay, thank you all so much for joining this afternoon. We hope you stay safe if you're on the East Coast and getting dumped on with snow. And we'll be sending out a survey and would love your responses and participation. Let us know how you like the series and any ideas you may have for the next one. Thanks so much. Take care.